Parkinson disease. Parkinson disease, PD, is a disorder of the automatic processor of the brain which relies on dopamine to maintain movements at a selected size and speed. Loss of dopamine causes movements to become smaller and slower. The pathological features are loss of dopamine-producing neurons from the substantia nigra in the brain stem together with Lewy bodies in the neurons. Genetic factors occur in 5% of individuals. The classic tetrad of PD is tremor, at rest, rigidity, bradykinesia, poverty of movement, postural instability, loss of postural reflexes. The mean age of onset is between 58 and 62 years. The incidence rises sharply over 70 years of age, peak 65 years. Hemi-Parkinsonism can occur. All the signs are confined to one side and thus must be differentiated from hemiparesis. In fact, most cases of PD start unilaterally. Always consider drug-induced Parkinsonism. The usual drugs are phenothiazines, butyrophenones and reserpine. Tremor is uncommon but rigidity and bradykinesia may be severe. Other causes include vascular, atherosclerosis, and normal pressure hydrocephalus. Signs of PD are power, reflexes and sensation are usually normal. The earliest abnormal physical signs to appear are loss of dexterity of rapid alternating movements and absence of arm swing, in addition to increased tone with distraction. Positive frontal lobe signs, such as grasp and glabellar taps, only allow 3 blinks, are more common with Parkinsonism. Diagnosis. Sometimes this can be very difficult, especially when the tremor is absent or mild, as occurs with the atherosclerotic degenerative type of Parkinsonism. As a general rule of thumb, the diagnosis of PD is restricted to those who respond to levodopa, L-dopa. The rest are termed Parkinsonism or Parkinson plus. There is no laboratory test for PD, it is a clinical diagnosis. Hypothyroidism and depression, which also cause slowness of movement, may cause confusion with diagnosis. 3 major traps in missing early diagnosis. Age. 10 to 15% are less than 50 years at onset. Belief that it is a disease of men. M equals F. Absence of resting tremor. Only 50% have it at onset. Management. Provide appropriate explanation and education. Explain that PD is slowly progressive and is improved but not cured by treatment. Support systems are necessary for advanced PD. Mild disease. Anticholinergic medications, benztropine and trihexyphenidyl, relieve tremor and rigidity. It is unclear why blocking acetylcholine improves symptoms of insufficient dopamine. Adverse effects of dry mouth, worsening prostate hypertrophy, and constipation occur more frequently in older patients. Amantadine may work by increasing the release of dopamine from the substantia nigra. Severe disease. Inability to care for themselves, orthostatic, dopamine agonists. Pramipexole and ropinirole are the best initial therapy in severe Parkinsonism. Apomorphine is a dopamine agonist. Rotigotine is an alternative, which is dispensed as a patch. Levodopa, carbidopa, the most effective medication. Associated with on-off phenomena which results in episodes of insufficient dopamine, off, characterized by bradykinesia. The on effect is too much dopamine, resulting in dyskinesia. COMT inhibitors, tolcapone, entacapone, extend the duration of levodopa, carbidopa by blocking the metabolism of dopamine. Used only in those treated with levodopa, carbidopa. Use when there are on-off phenomena to even out the dopamine level, or when the response to therapy is inadequate. MAO inhibitors, rasagiline, selagiline, as a single agent or an adjunct to levodopa, carbidopa. They block metabolism of dopamine. Deep brain stimulation. Electrical stimulation is highly effective for tremors and rigidity in some patients. Avoid tyramine-containing foods, e.g., cheese, with MAO inhibitors. They precipitate hypertension.